All right, so pain in the butt, abdominal stuff, and all that stuff. There, oops, do have a little bit. Change the disclaimer around a little bit, just from the aspect of school versus life. In school, we're taught lessons, take a test. In life, we're given the test, and that teaches you the lessons. So I was trying to actually find something funny about all that stuff. Like everything else, then anatomy phys. The GI system pretty much is from mouth to anus, depending on most of the organ systems of the GI are in the abdomen, and that's where we'll be diving into in a little bit. Everything digestion begins in the mouth, chewing process called mastication. And then we do start having some other digestive properties going on inside the mouth. Usually, it's most of your um, glucose type foods, your starch, all that stuff is really broken down. And you also do have absorption in the mouth, i.e., your oral glucose. Okay, that's why we give it that way for those type patients because you can absorb some of the sugar and all that stuff. It's broken down and then absorbed in the mouth and then down the rest of the side of it. Digestion, pretty much it's the parasympathetic. This is your rest and digest. Remember that? Okay, so it's the predominantly coming from the vagus nerve down. Um, there's also multiple other hormones, pepsin, cytokines, and all that stuff that help with the motility system. I'm really not going to talk much about that. The esophagus or esophagus, depending on who you talk to, it's usually a collapsed um, organ system, but then from there it does allow for movement. And what is the movement term called going down the esophagus? Swallowing. But then from there, what's the forward propulsion of food is called, starts with the P, peristalsis. Okay. One of the problems, though, of course, when we are potentially the airway, BVMing, and all that stuff, since it is a hollow organ, there's nothing that really stops air going into the esophagus, which goes down into the stomach, which then goes down into the large intestines, our small intestines, large intestines. Okay, so that's how we get our gastric distension and all that stuff with positive ventilation. Peristalsis, and then from there. Down at the bottom of the esophagus is where the portal vein is kind of sort of intertwined along with the vagus nerve. There's two branches of the vagus down in that, but don't worry about that. In the portal vein, the purpose of that, when we talk a little bit later, was cirrhosis and the bleeding and all that stuff is because of that portal vein system, or it's called anastomosis. It's a low pressure system that can actually back upwards from the liver, which expands the blood vessels around the lower esophagus. Okay, so what happens when those blood vessels break? So cirrhotic patients, liver failure, blood vessels, they're known to have problems with. Okay. So the blood vessels break. What do? They bleed. Okay. So this is your esophageal varices stuff. Okay. They throw up the blood and they can die from it. All right. We'll talk about more like that in a little bit. Um, food goes through the cardiac sphincter. Unlike the pyloric sphincter, the cardiac is not a true sphincter where it's a muscle. The cardiac sphincter is actually really more along the diaphragm, or it's the diaphragm that kind of sort of and holds it together and pulls it together. Um, with that, if the diaphragm kind of apart and moves, the esophagus, the stomach, and all that stuff can go upwards, and that's where we get hiatal hernia. And that's also the aspect of with people with reflux, GERD, and all that stuff. That's where they hit the feeling of having chest pain for that exact same reason. Goes into the stomach. There's what's called proteases, which are the digestive enzymes, and then hydrochloric acid. The hydrochloric acid drops the pH down, which allows for the proteases to work. But then from there, the hydrochloric acid, that's one of the immune system, part of the immune system of controlling the bacteria. All of that's kind of sort of tossed around into the stomach, and then ultimately it goes away from quote unquote food to a product called chyme. And the chyme then goes into the small bowels. Questions thus far? Anatomy review. All right. The other important factor for the stomach and all that stuff is the intrinsic factor here, which is released from one of the two different types of cells in the stomach. The intrinsic factor is with vitamin B12. All right. It binds to B12, which in turn allows for it to be absorbed into the small intestine. All right. The problem here is some of your bariatric surgeries, okay, they kind of sort of take out the top part of the stomach when that's where the intrinsic factor is produced. So we have a lot of patients that have the potential of having B12 deficiency, and B12 is part of the nervous system and also blood production. So think about and all that stuff. It's also your alcoholics. They have problems with this too. Or I should say drunks. Alcoholics quit and go to meetings. GI systems, again, the whole purpose is to absorb the digested food. Duodenum is connected to the liver, gallbladder, and pancreas. Whole bunch of different ducts and all that stuff. And then the pancreas, the whole purpose of that is it's the major thing of releasing enzymes to help break down some of the protein and some of the fat. And then also it helps neutralize the acid that's coming into the small intestine. If not, it would burn all the way down and go from there. Small intestines, 3 parts, 90% of absorption, duodenum, jejunum, and ileum. The duodenum is this little first part here from the stomach coming down, and then you have at the ligaments of Tract all the way down till almost the very end is the jejunum, and then the terminal part is the ileum, which attaches to the cecum, and that's where the appendix is. We'll show that in a little bit. Pancreas here looks like a football. The tail is nestled into the spleen. The head is actually, the duodenum is buried through the head of the pancreas. So a lot of people that have pancreatic cancer, which we won't talk that much about, a lot of times they talk about the duodenum and all that stuff. The gallbladder or the bile duct goes through the pancreas. So again, with the pancreatic cancer, they take all of this part out through what's called a Whipple procedure. Liver produces bile. The other portion of it is detoxifying drugs. That's really the good thing. You can live with about a quarter of your liver before we start really dying and all that stuff. The liver is the only organ in the body that actually cut it in half, as long as you have blood supply and transplant it, and it will grow back. So it's a very remarkable aspect. What's the other major thing that's the liver? What else does besides the vitamins and minerals, what else does the liver store that is really important for us? Fat, some part, okay. Something else. Diabetics need it, okay. Doesn't store it, and it's produced in the pancreas, but it's something that the insulin tells the liver to break down. Glucose through glycogen and all that stuff. So you basically have that the glycogen is broken down into glucose, and then from there it allows us to increase our sugar. So patients that have liver Okay, they don't have that. Thereby, if you give them different types of medications to help increase the glucose, it doesn't work. All right, gallbladder. The only real purpose of the gallbladder is to store the bile, which in turns it gets emptied out. So the liver produces the bile, sticks it in the gallbladder, and then anytime you have fatty foods, um, pushed out. And the whole purpose of the bile is to what's called emulsification of the fat, break it down into little smaller pieces. And when we know that smaller pieces are more easily broken down and all that stuff. Pancreas, 6 inch, sits across the back of the peritoneum and all that stuff. On the right side, again, attached into the duodenum and all that stuff, tails into the spleen. Um, and its really purpose is it has two different things. One's exocrine, which is all of the digestive enzymes, and then the endocrine system, or going back when we gave that talk a year ago, with the insulin and then the glucagon. Made a mistake. Insulin builds up on the previous two slides. Glucagon is the one that tells the glycogen stores to be broken down. All right. And glucagon is one of the medications that in the future I'm going to do a study on with EMTs to be able to give intranasally to see if we can test and all that stuff. Because it's not one of your medications that you can give but as an advanced EMT. EMTs cannot give intranasal glucagon. Yeah. Yep. It's no worse than Narcan up the nose. Well, I mean, if these people have a sugar of 15 and they're unconscious, colon, large intestine. The whole purpose of the colon is really to absorb the majority of the colon from the cecum on up over to the descending colon is really to absorb water. And then the last portion of it, the sigmoid colon, is a storage for feces. And then the anus or the anal, all the anal and all that stuff, this is the terminal portion of the GI system. Absorb water. Do you have some bacterial digestion that occurs? And they say it can take anywhere from 8 to 72 hours after you eat food to go from the mouth to the anus, depending on what it is. Blood vessels. There's a whole bunch of different things in here, depending on which. Basically, every organ has at least 2 blood supply coming to it. Not going to really bore you with all that stuff. But the big thing to draw a conclusion on is the aorta in the inferior vena cava goes straight through all the abdomen. Portion right here is called the bifurcation, and that's the belly button. Okay, so a couple things with this. Of course, if patients are complaining of abdominal pain around the umbilicus and all that stuff, elderly patients, things to think AAAs or the abdominal aortic aneurysms. All right. And with pregnant females, why is that so important? Why is this region so important? Okay. Baby lays on it at what age or what station? Second trimester. What part of second trimester? So 20 weeks. All right. 20 weeks is that magical numbers. That's when the uterus is big enough that it can actually start sitting on your aorta and the inferior vena cavas. Okay, that's why after 20 weeks we put them in the left lobe decubitus position so that they don't compress that and develop IVC syndrome. And we'll be doing pregnancy again in the future. Whole bunch of blood vessels. Again, from the aspect of the hepatic veins up around the esophagus, they kind of sort of attach there. along with blood supply coming from the esophagus down, and that's where you get the portal, what's called the portal naval anastomosis. And then down in the rectum region, it's the same thing. You have blood supply around the anus, along with some of the blood supply from the legs going up, and you have a anastomosis, naval anastomosis system here. I mean, that's the majority of the reasons why patients have hemorrhoids with liver failure. Again, these are low pressure systems that allow for the blood, the blood vessels to expand open, and then from there burst and have problems and all that stuff. Can't find really many good funny slides with digestive system. All right. Any questions? Anatomy. Good. Okay. We all need it. All right. So from here, what we'll do for the next little bit is just talk about acute abdomen, and then we'll get into the breakdown of differences between inflammatory versus your infectious versus obstruction versus bleeding. That's kind of sort of where the majority of the bulk of the rest of the slides will be. And then that will be a little bit of pediatrics and traumas and all that stuff. So yes, we'll make sure that you get a little bit more than the other day. General purpose, again, acute abdomen is just the presence of signs and symptoms of inflammation. Okay, itis. Anytime you see itis on the end of something, diverticulitis, peritonitis, your cholecystitis, inflammation of or irritation of, pancreatitis again. So in the hospital, the pre-hospital, I don't really care if you guys can come up with the problem. All right. What you really need to make sure is, can you diagnose it, or can you see that this is acute abdomen, and then figure, do you need to stay or play or let them go? Is this a sick or not sick patient? Which is one of my talks at the Partners for Life. Different causes: inflammation, blockage, swelling. You can have stretching of organs, stretching of the itself, blocking of the duct, gallbladder, or blocking the common bile duct, blocking Stenson's duct, which is the duct from the pancreas into the intestines and all that stuff. Or do we, knock out mesenteric in older patients with atrial fibrillation and knock off the blood supply to the abdomen, and now they basically have their whole GI system, crash and burn. Visceral pain is just a organ. It's the all the pain receptors going into the organs. So we have the visceral, somatic, and then referred are your three different types of pains. The visceral is usually your organ pain. Pinpoint, you can kind of sort of say, yeah, it hurts right upper quadrant. Okay, what's in the right upper quadrant? Liver and gallbladder, head of the pancreas, intestines, kidneys. Okay, so, and we'll talk about all that stuff a little bit. So you can kind of sort of say, that they know exactly what it is, and it's a little bit of crampy, colicky. The pain comes and goes, and then they have some other signs and symptoms of cardia and all that stuff. Versus the somatic, this is more of irritation of the peritoneum. It's just a generalized. It hurts all over. How many have had that little, 5-year-old kid going, yeah, it hurts all over. Okay, you touch everywhere, and then it goes from there. And then it's constant moving, coughing, and all that stuff. And then the referred is the radiation pain. This is the patients that have, in a trauma, they have a spleen rupture and they're complaining of left shoulder pain. Your MIs that are, the females, they complain of abdominal pain, but they're really having a myocardial infarction, the epigastric pain and all that stuff. Testicular torsion referred with abdominal pain. Even strep throat in kids can have referred pain into the abdomen and all that stuff. All right. So things to ask and what to do, how we're looking at things. So, of course, history, got to know your organs, where things are located. Okay? If you don't know that, guess what? Got to go back and study. That's the only way that we can really come up and make an appropriate assessment and all that stuff. Was it gradual? Was it sudden? Did you get shot? You know, do they have a perforation, anything like that? How does it feel? Is it a steady cramping, or is it steady pain? Is it crampy pain? Sharp shooting, all that stuff. From there, does it go in? All right, right shoulder again, the or the liver, gallbladder, and all that stuff. Flank, are they having flank pain that's going around into the testicle? That's a telltale sign with the kidneys, the ureter. Do they have kidney stones or something like that? Pains and locations and all that stuff. Usually, the most part, they're the shoulders, the liver, the liver, gallbladder, and all that stuff. The other shoulder with the spleen, pancreas, because the tips and all that stuff. And a lot of it is because of how we were in embryo. All the nerves kind of sort of stretched and expanded and all that stuff. Other things to ask about duration, okay, nausea, vomiting, coffee. Okay, so coffee ground emesis is what? Okay, so from there, the hematochezia. What's the term hematochezia? Or melena. So hematochezia is bright red blood from the rectum, okay, or is that black tarry stools. So any urinary problems, color, bowel movements, appearance, the melena or hematochezia, and then from there, it's not always the aspect of what does the diarrhea or look like. Ask how frequency if they're having diarrhea. Is it watery? The consistency. Like a lot of that stuff can take into consideration. Females always ask about their last menstrual period, abdominal bleeding. Okay, so again going back to the OBGYN, abdominal pain with vaginal bleeding is okay. Miscarriage or until proven otherwise, it is a GYN. Ectopic pregnancy until proven otherwise. All right. So just to reiterate, signs and symptoms: guarding. Okay, they don't want you to touch their belly at all. Rapid shallow breathing, pains, any hypertension, tachycardia, all the other signs and symptoms. Do they feel constipated, bloody stools, and go from there. So on the assessment side of things, we're going to look at BSI seen safe, sick, not sick, kind of sort of do your focused exam, and then look at the detailed overall assessment and all that stuff. So on your guys' guidelines for abdominal pain, again, history, kind of sort of go through all that stuff, any of the signs and symptoms: diarrhea, dysuria, constipation, bleeding, pregnancy, associated symptoms, and then the whole laundry list of differential. It can be massive depending on locations and all that stuff. NPO, hypertension, rescue guard, which you guys do have the spring here, and then from there, if they're over 40, they should get an EKG. All right. Again, if there's, unfortunately, I've seen even some late 20s, early 30-year-olds having MIs with complaint of abdominal pain stuff. So it's not always a good aspect. From the advanced EMTs and paramedics, you'll be able to do a little bit more. Are they having acute abdominal aneurysm? If they do that, then of course they go down the acute abdominal aneurysm guidelines, which is dropping the blood pressure. Signs of hypertension, giving IV/IO access, giving fluids. Are they vomiting? Oral Zofran for advanced EMTs and all that stuff. Medics can give their Zofran and Phenergan, and then pain control and go from there. Physical exam, of course, look at general appearance. Are they laying still? Are they rolling around? Are they walking? Jumping up and down. That's the last telltale signs for kids. If they have belly pain, what I'll do is I'll actually have them jump up and down. If they jump up and down, I pretty much know that there's not much going on for them. Because the kids won't fake it. Okay, if they won't jump up and down, there's usually something going on. Distension, ecchymosis around the umbilicus or flanks, which is colon signs or Gray Turner, which we'll see that in a little bit. Tachycardia, shallow breathing, which is another telltale sign for peritonitis, and then any of the postural changes and signs and symptoms of shock. Secondary assessment, okay. Sometimes you have to have them flex their knees, looking at striae. Okay, these are your striae, all the stretch marks and all that stuff. Not just in females pregnant and all that stuff or previously pregnant, obese. Also, what other patient population will have the striae? Bueller. Hmm. Bariatrics, the obese, yeah. People that have liver cirrhosis, they get a lot of the striae. So is it asymmetric tumors? Nothing kind of sort of funny when you're sitting there watching their belly and one side of the abdomen gets protruded out and then goes back in as they taking in deep breaths and all that stuff. And then any of the shapes of the abdomen. Is it scaphoid? Is it um, flat abdomen and all that stuff? Protuberance, weight gains, ascites, pregnancy, of course, or any of your organ enlargements. Um, this is a bad sign. Right? Bowel sounds. If you actually listen to bowel sounds, great. They are, for the most part, don't give much information. My old surgical attending, he was like, they don't really do much for us. This thing is just really the aspect if you have absent bowel sounds with ileus or peritonitis. Borborygmi, I always like that term. I can still remember when I was nursing, that was the first time I ever heard of borborygmi, which is that you hear the gurgling sound and your friend's stomach is gurgling, you hear it. That's the borborygmi. And trauma not much value again for auscultations. But we do want to get into the process of though of percussing and then the palpations. All right. So percussion is any of your tympanic. Doesn't matter where you start. You just need to start again. It's your own systematic way and all that stuff. The left upper and right upper should be a little bit duller. Okay. Why should the left upper and right upper quadrants be a little bit duller? Correct. All right. So you got the liver there. On the left side, you got the spleen. You got some of the intestine, the pancreas, and all that stuff. So from that aspect, it's really you don't get that nice drum beat that you can have in the lower abdomen, all that stuff. Palpate. All right. Wear your gloves. Wear your gloves. Wear your gloves. Warm your hands, kind of sort of have the patient that they can bend their knees, and then start furthest away from the pain, and then move towards the pain and all that stuff. Other aspect is you're trying to indent at about 2 to 4 inches. You're trying to feel it for what? Distension. Okay. Masses, fecal material. Okay. all that stuff that you're trying to push through and all that. Got to know what's in your quadrants. So right upper is your liver, gallbladder, and part of the large and small intestines. Right lower is your appendix, small intestine, fallopian tubes, and ovaries in the females. Of course, left, and then again, small and large intestine, ovary, and a fallopian tube. And then your left upper quadrant, your stomach, spleen, pancreas, part of large intestines, part of the small intestines are there too. All right, and then the diaphragm kind of sort of splits the cavities. Rebound. All right, this is where you push down into the belly and then let go, and then they have pain. They can sometimes jump off the bed. That's your quote unquote rebound tenderness. The other one that I'm actually doing is a heel tap or bumping the stretcher or the bed or something like that. That's a really, from the aspect of trying to assess for peritonitis. Because again, some patients, they just, everything hurts, but then from there, if you tap them, and they're like going, "What are you doing?" And they don't have much going on. Or the other question is, how did you, driving over here, how did you do driving over? Or if you're driving in the ambulance and your partner is going really fast and hitting all the bumps in the streets of Toledo, if the patient's jumping off the stretcher, that's another telltale sign. Murphy sign. This is for from the aspect of cholecystitis. This is really when you take in a deep breath or the patient breathes out, you push your hand up into the right upper quadrant and then have them taking a deep breath. If they jump off the bed, then that's a positive Murphy. Orthostatics. There's a whole bunch of different literature. I still do have it in the guidelines for performing orthostatic and it doesn't give you much value for volume status. It does give you some of the other things like for Palpate syndrome or the neurocardiogenic syncope or something like that. So on orthos, have the patient laying flat, sit them up, and then wait a minute, take the blood pressure and heart rate, have them stand up, take their heart rate and blood pressure again, just as a reminder. If the blood pressure drops more than 20 or their heart rate, the heart rate is a better indicator than blood pressure. Right? When we normally stand up, what does our blood pressure do? Our blood pressure will drop and our heart rate will go up. That's a normal phenomenon just because of gravity and all that stuff, which is one of the questions on Jeopardy last night. Other things to kind of sort of take into consideration, anyone over 30, consider cardiac, females, possible any of the GYN, okay, abdominal, lower abdomen, pregnant, age, they have an ectopic until proven otherwise. Geriatrics, anything can go with the geriatrics just from what we talked before. Alrighty. So we're going to talk about, but we're going to break this down and again into 4 huge categories. So your AAA's appendicitis, bowel obstruction, cholecystitis, cystitis, diverticulitis, ectopic, peritonitis, peptic ulcers, kidneys. This is really, is it inflammatory? Is it infectious? Is it obstructive? Or is it a bleeding? All right. So knowing more of the classifications or the general stuff is really what we're going down for. And again, looking at everything, if you go from the 4 quadrant to the 9 quadrant, this kind of sort of gives you an idea. There's a lot of potential stuff going on there. General management, like everything else, airways, if the person's not breathing, nothing else really matters. I don't care. And then from there, again, make sure that they don't eat or drink, comfort, calm, maintain body temperature. Monitor vital signs, anticipate vomiting, for the advanced EMTs, paramedics, giving them nausea medicine or pain as needed. Cardiac, over 30, over 40, guidelines says over 4, or the guidelines say over 40. But if it kind of sort of looks like a cardiac or something, and you have a medic there with you, get an EKG. I don't care. Okay, it's only paper. And then females, just to reiterate over and over and over again, it's ectopic. ALS, when to call, try to getting your backup, tachycardia, hypertension, and then any of your vital signs, postural changes, it just won't go away. So this is kind of sort of what we'll be looking at and broke down and going from there. Any questions thus far? Nothing? Nothing? Alrighty. We're quiet today. I'm sorry. All right. So any of the acute inflammatory conditions, okay? Anything that causes inflammation in the bowel or in the organs and all that stuff. Itis, ITIS, irritation, inflammation of. Okay? You can have autoimmune, you could have blockage, and then from there it's different and all that stuff. Swelling, irritations. First one is pretty much the appendicitis. All right? Swollen, irritated appendix. Where's the appendix located? Okay, lower right. Usually it's caused by a cliff or a hard poop that just kind of sort of gets stuck there. There's actually a number of people nowadays that are not even being born with appendixes. Evolutionary it's a worthless thing. A couple hundred years ago, we needed the appendix to help for the breakdown of red meat and all that stuff. Now that we're cooking it, it doesn't matter. Bile pressure causes rupture. So this is the person, the person that you have to be concerned about is they're complaining of right lower quadrant pain. It's cute, it hurts, it looks like an appendix, and then the pain goes away. Okay, those are the patients that they ruptured their appendix, and now they'll start develop peritonitis, sepsis, and death. Okay. All too often we've had bad things happen with that. Early, they get the parambilical, nausea, vomiting, and then as it starts getting quote unquote ripe, it moves down to the right lower quadrant. And what is that location? What is that point called? McBurney's? Never heard of that, McBurney point? Okay. So McBurney point, what they say it's 1/3 to 1/2 between the umbilicus and the right iliac crest. That's kind of sort of where they say the appendix lies. But it can be anywhere in the right lower quadrant. It could be McBurney's point. People don't always have pain in the right lower quadrant if they have a flipped appendix, if it's laying, vertical, or if it's laying horizontal, going across behind the bladder, or stuff like that. And ultimately, the last presentation is where it's ruptured and the pain decreases, but that's a telltale bad sign. Dunfine sign is pain when you cough, and then from there we'll have a couple others, signs and all that stuff. Sorry about that. Or septicemia, basically infection. They're becoming septic. Fast heart rate, elevated white count, fast breathing with signs of infection. And pretty much treatment for this is fluids. And then nausea control and all that stuff. Cholecystitis, irritation, inflammation of the gallbladder. Okay. So you can have what's called cholangitis, which is bile duct, or the cholelithiasis, which is stones in the gallbladder. Cholecystitis, of course, is the gallbladder, or the acalculous cholecystitis, where you don't have you have inflammation of the gallbladder without gallstones. Um, Acute cholangitis in elderly patients can kill them very easily. So older patients, right upper quadrant, again, that's one of the major things that we think about. Gallstones are the most common, 30 to 50 in females. So it's the 40 female, fat, fertile is the presentations that they always say and all that stuff. And then from there, fatty foods is a huge trigger. So when you're asking them, when does it hurt, what happened, what's going on, does any food make it better or worse, and all that stuff. They have Murphy sign. Again, what is Murphy sign? We just talked about this. So you have them out, you push into the upper quadrant, then you have them breathe in again, and if they jump off the bed or punch you in the face, that's a positive Murphy. So it's pain if you're pushing in the right upper quadrant. All right, nausea, vomiting, and jaundice, and all that stuff. Fatty meals, right upper quadrant, management, stop. Don't let them, eat anything, pain medicine, transport, and all that stuff. Diverticulitis. So a diverticula, okay, or diverticulum are the little out pouches. Okay. It's a hernia of the intestines is what it is. So you have the smooth muscle that's going down the intestines. The wall of the intestine kind of sort of pushes through the muscle and it pushes out. All right. The most common location is the left lower quadrant. You have one? Okay. It hurts. Yep. And that's the next slides. Yeah. So the diverticulitis is the inflammation of the diverticula. Most common, again, seen in your 40s, 50s, 60-year-olds. As we get older, that's when we start getting the hernias and all that stuff. Pouches become blocked, fecal matter, seeds, raspberries, strawberries, those sort of things you're supposed to, or nuts are another big culprit. They can have some microperforations and then develop peritonitis and all that stuff. So low fiber diet, diet low in fiber, creates more solid states. From there, you want to, other things that can cause, again, is the inflammation, the infections, adhesions, scarrings, and fistulas. Those are complications of diverticulitis and all that stuff, or rupture. Abdominal pain, usually left lower. They also might complain of some constipation and diarrhea and all that stuff. Okay. Antibiotics, liquid diet, surgery if needed. Again, not much for you guys to do in the pre-hospital setting, transporting fluids for medics, advanced EMTs, and all that stuff. NPO. Pancreatitis, right? Irritation, inflammation of pancreas. All right, dude. You suck. All right. The pancreatic duct or Stensen's duct goes all the way down the pancreas. So anytime that this gets blocked, and usually the most common culprit is after infection, you can actually have the gallbladder. A stone comes down and it blocks the end of the duct and stuff. All right. So enzymes can't get out of the pancreas. So what happens? You have a blocked duct, you got a blocked plumbing, okay? It ruptures, and then it starts eating itself. All right? And that's where a lot of the problems come from and all that stuff. Alcoholics, fatty foods, and all that stuff are another leading telltale problems and all that. suddenly or over months, some people only have one attack, some people have frequent multiple attacks and all that stuff. If it gets bad enough, the pancreas dies completely. They have to go on insulin and all that stuff. Classic epigastric pain or right, and it goes straight into the back. Now, that is the quote unquote classic pain and all that stuff. Um, Other potential causes, problems, children with handlebars, so they go over their handlebar, ram themselves, and actually say scorpion bites too. Yeah, that's what I had to say. All right, I got these in the wrong spots. Apologize. This is actually supposed to be for appendicitis. So psoas sign, if you have the person lay on the left side and you pull the leg back, the psoas muscles on the front of that, and if it irritates the psoas muscle or they have pain there, that's a telltale, one of the telltale signs for appendicitis. The other one is the obturator. Again, the obturator is one of the muscles, so you have the person flex their knee and you rotate their leg in and out. And if the muscles, when you're sliding the muscle back and forth, and if that irritates the leg or it irritates that right lower quadrant, that's another telltale for appendicitis. All right. So again, two things that we talked about earlier with the bleeding sign, the colon, the gray Turner. So you can sometimes have this with your bad appendicitis and all that stuff, or bad pancreatitis, where they have ruptures. So we get a little bit of the bruising around the belly button. Okay, that's colon sign. Is you see that right there? So they get bilateral flank bruising. Okay, that's gray Turner. Okay, they're having a posterior or retroperitoneal hematoma and all that stuff. I've seen this once. Patient didn't make it. Not good. Management again, if it's bad bleeding, all that stuff, hydrations, pain control, and go from there. Right. Irritable bowel disease versus IBS or irritable bowel syndrome. Uh, there are actually a lot of people that are saying now IBS is another form of depression, or a lot of people with depression kind of sort of has IBS. So they're using a lot of antidepressants with IBS versus IBD, which are irritable bowel disease, Crohn's versus colitis. Crohn's is pretty much from mouth to anus, skip lesions, real bad, versus the colitis, the colon, that's the inflammation of the colon itself. IBS, hypersensitivities, the pain receptors, they get a hyperresponsive to the smooth muscles. Again, some thinking that it's a little bit of a depression going on and all that stuff. Cause constipation, bloating. They a lot of times beginning in childhood, various triggers. These are the ones that they're just constantly, chronically having to go with diarrhea, belly pains, and all that stuff. Typically, just they have flare-up symptoms, management supportive, and then from there, a lot of patients over time they become depressed, more depressed. They just don't like life and go from there. Crohn's disease, entire GI. You can have anything from the mouth all the way down to the rectum, anus. And it has areas of scarring, narrowing. They can develop a lot of obstruction as a common problems with your Crohn's disease. A lot of people out there with that. Some they're thinking genetic, some they're thinking immunologic, some they're thinking that it's a environmental. We really don't have a good rationale and all that stuff. Patients, still from the aspect, they do have the bleeding, weight loss, the chronic abdominal pain. Sometimes they have to have part of their intestines removed, large intestines, small intestines, and all that stuff. So they can have nutrition problems and all that. Pre-hospital is pretty much just making sure that they're volume resuscitated and controlling the nausea and pain and all that stuff. UC or ulcerative colitis, inflammation of the colon. You get the thinning of the intestinal wall. Then from there, they can have, again, the same thing similar to like Crohn's disease, bleeding and all that stuff. And a lot of the UC is bimodal, 15 to 25, and then over 55 and 65. Some people do in the 40s and all that stuff. Gradual onset blood diarrhea, okay, the hematochezia, okay, the bloody diarrhea, the bright blood versus the melena which is your black tarry stools and all that stuff. Hemodynamics, give fluids if need be, and then pain control and all that stuff. Right. So it's halfway through. Do you guys want to take a break or keep going? All right. So we'll take a break for 5.